Welcome to the GSA webinar, From Basic Science to Policy, applying the NIA Health Disparities Research Framework across disciplines in aging. Next slide. We have a few housekeeping items to go through, but first, please introduce yourself in the chat. We'd love to know who's here. We also will use the chat box throughout the presentations, so please comment or ask questions, which will be directed to the panelists after the presentations are completed. Our program is being recorded today and will be archived on the GSA website. We ask you to keep your video off and audio on mute until it is time for discussion. A question and answer session will immediately follow the live presentations. Next slide. My name is James Powers. I'm a professor at Vanderbilt University and chair of the GSA work group to help produce these presentations. Today's webinar is part of a series for early career scientists and young investigators. The Gerontological Society of America presents this essential episode oriented to scientists investigating health disparities related to aging, including environmental, socio-cultural, behavioral, and biological factors. A pre-recorded overview of the NIA Health Disparities Research Framework by Dr. Patricia Jones, Director of the National Institute on Aging, Office of Special Populations, is available on demand from GSA's website. Today's panel will cover cross-disciplinary approaches from different career stages. Panelists will discuss how they have applied the NIA Health Disparities Research Framework in their work. First, we'll hear from Dr. Kelisha Bonds-Johnson, Assistant Professor of Nursing at Emory and Vice Chair of the GSA Emerging Scholars and Professional Organization. Next, we'll hear from Crystal Glover. Dr. Glover is Associate Professor at Rush Alzheimer's Disease Center, Department of Psychiatry and Behavioral Sciences, Division of Adult Psychiatry, and Department of Neurologic Sciences at Rush Medical College. And finally, Dr. Amy Kind, who is Professor of Medicine and Associate Dean for Social Health Sciences and Programs, and also Director of the Center for Health Disparities Research at the University of Wisconsin, School of Medicine and Public Health. We welcome all of you here today. Without further delay, I'm going to hand the microphone over to Dr. Johnson.
Hello, everyone. Let me get my slides up and we will get started. We'll be on there. Okay. So hello, as he said, I am Kelisha Bonds-Johnson. I'm an assistant professor and psychiatric mental health nurse practitioner at Emory University, as well as the vice chair of ESPO. My presentation is entitled, "It's Only the Beginning, Views from an Early Careers." As I describe my work, I will use the phrase dementia dyad or dyads throughout this presentation. Dementia dyads consist of two people, and in this presentation, I'm referring to the person living with dementia as well as their care partner or caregiver. In this presentation, I'll highlight the importance of a conceptual framework or theoretical framework, how I use the NIA Health Disparities Research Framework in my own work, and then end with some considerations for early careers. Throughout my PhD program, the importance of using a theoretical framework or conceptual framework was repeatedly stated and emphasized in quantitative research. We know in qualitative research, there are caveats, as often one is generating a theory or a conceptual framework, so it may not be emphasized the same way, but definitely in the quantitative work. I think of a theoretical framework as a roadmap to guide my study design, data collection, and especially my data analysis. And with each level of my development as a nurse scientist, I've become more and more comfortable with this approach. In my dissertation study, I used the Negro family as a social system which was developed in 1968 by Dr. Andrew Billingsley. While the word Negro may cause some to feel discomfort or uneasiness, it was the appropriate term of the time and a step up from what African Americans were previously called. For those who are feeling some way about this word, I would encourage additional self-work. You see, during my dissertation, this conceptual framework guided the research and helped me figure out how to set up my research questions. The conceptual framework not only guided my work, it grounded me. The persistence of African Americans, despite how we entered the US, is empowering and makes me proud to be an African American woman. The Negro family as a social system is comprised of three networks: the Negro family, the Negro community, and the wider society. The Negro family consists of family structures, instrumental and expressive role functions. Family structures describe the family network, such as two-parent households, single parent, and blended, and was operationalized in my dissertation as the caregiver type, or whether or not the African-American caregivers were spouses or non-spouses. Instrumental role functions consist of maintaining physical and social integrity of the family unit, including decision-making, educational attainment, economic provision, and maintaining health. And then expressive role functions are characterized by maintaining social and emotional relationships among the family unit, including positive and negative emotions, self-worth, and belonging. The Negro community should be considered a racial subsociety with great heterogeneity, which includes geographic regions and businesses. And lastly, the wider society encompasses the healthcare system, political system, and educational system. As was previously stated, I know Dr. Jones' presentation has been viewed and shared and seen and gave more detail about the NIA Health Disparities Research Framework. I just wanted to remind you of the levels of analysis as I show you how I expanded on my dissertation research in my K-23 that was awarded by NIA. So using the Negro family as a social system conceptual framework, I was able to identify heterogeneity within the caregiving experiences of African-American spouse and non-spouse dementia dyads. African-American persons living with dementia who reported less decision-making involvement, and this is daily decision-making, and whose caregivers were non-spouses were significantly more likely to have worse quality of life. African-American caregivers who experienced significantly worse quality of life when they were non-spouses of the person living with dementia and when they reported greater dyadic relationship strain with the person living with dementia. Most of the non-spouse dementia dyads were adult daughters caring for a parent, which helped me refine my focus to African-American adult daughters caring for a parent living with dementia. So as my thinking evolved and my program of research is starting to come to fruition, I needed theoretical and conceptual frameworks that would guide my work. The Negro family as a social system guided my dissertation research, but I must admit there were a couple of shortcomings with using it. First, the conceptual framework was more like a grand theory than a middle range theory, which sometimes hindered my ability to operationalize concepts. Second, the smallest unit of the theory was the family unit, limiting the individual in analysis. And lastly, I wanted a more explicit way to examine health disparities in my population of interest. To overcome these shortcomings in the model and highlight the importance of both members of the dyad individually, I used an adapted conceptual framework that includes three conceptual frameworks. First, the Black family social ecological context model, which incorporates the Negro family as a social system, is a conceptual framework that allows for the examination at the level of the dyad or the family, as well as at the level of the individual, while still considering societal and community influences. Second, the NIA Health Disparities Research Framework, or Why We're Here, was added to highlight the importance of the life course factors, which, if you remember from the previous slide, environmental, sociocultural, and behavioral are those levels of analysis, which I'll discuss more on my next slide. And then the last adaptation of the framework was adding the Superwoman schema, which focuses on influences of cultural characteristics of African-American women. And based on the key findings from my dissertation, I wanted to include a framework that would capture the cultural experiences of these women. So you may be saying to yourself, yes, Kalisha, makes sense. Yes, Dr. Bonds-Johnson, that makes sense. I get it. But how did you actually apply the theory to your work? Well, here's how. Personally, I love a detailed framework, and I love how detailed this framework is. My research doesn't focus on biological factors, but at least not at this moment, so I didn't pay much attention to that column. The other speakers will address this section in their talks, I do believe. I started with the environmental column, and two boxes stood out to me when I was thinking about my work. Regarding socioeconomic factors, I knew that with demographic data, I could collect education and income quality. With healthcare, my work is focused on helping the adult daughters navigate the healthcare system for their parent living with dementia. So I included of health literacy measures, the realm is one example, as well as the Alzheimer's disease knowledge test, which is getting a bit out of date, but anyway, that's what I use in my K-23. And then also looked at the relationship quality. So I looked at how the person living with dementia felt in their relationship with their provider, as well as how the adult daughter felt about this relationship between parent and provider. Regarding sociocultural and behavioral levels of analysis, I did the same thing. The concepts in the box that were supported by prior research, or maybe had limited research, but seemed to be of importance to my analysis, were included in my analysis plan. I looked for ways to examine these concepts with validated measures. If there were no measures, I thought of ways to qualitatively get at the concepts. If I could leave you with 3 takeaways, it's this. First, your dissertation work, if possible, use your dissertation work, if possible, to support your future work. Even if the population of interest or the topic has changed, there is something you can take from your dissertation to advance your program of research. Second, don't feel limited by your theoretical framework. Yes, there should be alignment with the philosophical underpinnings of the theoretical frameworks or conceptual frameworks you use, but don't be afraid to include more than one. And third, one framework can guide your entire program of research. With the NIA Health Disparities Research Framework, there are so many concepts to examine and explore with each level of analysis that one can use this framework throughout their career. So I would like to acknowledge my funding since my dissertation work began, as well as my primary mentors on my K-23 and my dissertation. Here are my references, and then thank you. And are there any questions? If there are, please put them in the chat and we'll address them after all the panelists have spoken. Thank you.
Thank you so much, Dr. Bonds-Johnson, for a very enlightening presentation. And I will remind all of those participants to do indeed put your questions in the chat. We are looking to have a wonderful discussion at the end of all of the presentations. Next, I'd like to introduce Dr. Crystal Glover as our next panelist. Dr. Glover, when you're ready.
Hello, everyone. Thank you for having me here today. As I said, I'm Crystal Glover. I'm at the Rush Alzheimer's Disease Center here in Chicago, Illinois. Today, I'm speaking about a recent paper of ours focused on antecedents of perceived stress among older Black adults. So today, I want to start off with defining perceived stress, especially in the context of aging, and really drilling down even more so in the context for older Black adults. Here, I'll also talk about how I conceptualize perceived stress as an outcome using the NIA Health Disparities Research Framework. Then we'll talk through characterizing correlates of perceived stress for older Black adults before discussing next steps for research and policy. So currently, we have a larger and more demographically diverse group of people who are facing these unique challenges of aging. So you could think about changes in income, say living on a fixed income as people retire, perhaps moving out of their homes or downsizing, as well as experiencing the passing of family members, peers, and other loved ones. So these challenges may be exacerbated, especially for older members or older adults who belong to racial and ethnically minoritized groups. This intersection of age and race, these challenges can really induce feelings or perceptions of stress. When I speak about perceived stress as someone's subjective or their own evaluation of stress in their lives. So do they feel stressed? How do they feel about that? But also, do they think that they have the resources to cope with such stress? So do they have financial resources, the space to get outside and maybe take a walk, or the ability to convene with loved ones and others for physical, social, or other cognitive activities? We know from previous literature that perceived stress can impact, mitigate health outcomes, especially for older adults, meaning that higher levels of perceived stress can be deleterious for the health in older adults, and quite frankly, everyone, but we'll focus for older adults here. But previous studies have largely focused on perceived stress as a predictor, so meaning higher levels leading to. Well, I was curious about in my work, well, what precedes that? What are the antecedents of perceived stress, particularly for older adults, and what leads to higher levels of perceived stress? So the purpose of this work here is to identify these antecedents or correlates of perceived stress, especially among older Black adults. Undoubtedly, perceived stress is a challenge, is an issue for all older adults. However, it's particularly critical, I believe, to understand the antecedents of perceived stress for older Black adults, as they are a group of people that tend to have well-documented, objective, stressful, and other challenging life experiences, not just in older adulthood, but across the lifespan. And we also know that little is known about the topic of perceived stress, what comes before perceived stress overall, let alone among this particular group of individuals. So here at the Rush Alzheimer's Disease Center, we have a wealth of variables. So I wanted to think about it systematically. We know that I'm interested in the antecedents of perceived stress, but how can we have a structure, an organization for how these different levels of antecedents may impact perceived stress? So I took to the literature and I was really taken with the NIA Health Disparities Research Framework, as I know from previous literature that these different levels, environmental, sociocultural, behavioral, biological, all have different factors that are important across the lifespan, particularly in older adulthood, expressly for these priority populations, right to your right, including older Black adults. So we started thinking about, well, how can we have a structure for what we do have, and then be able to say, based on this framework, previous literature, and what we've seen in our own cohorts, how do we hypothesize these myriad of relationships? So here I'll walk you through the hypothesized relationships. Join me to the left. We start with level 1, environmental. So we have a few variables here, but really thinking about what we'll say be a protective mechanism for a perceived stress, higher levels of perceived stress, and what are risk factors for higher levels of perceived stress. So for level 1, environmental, more years of education, higher income, more life space, which means being able to get out of, say, your bedroom, into your living room, into your neighborhood and beyond. So just the space that you're occupying in your community, and also more neighborhood safety, protective, whereas more neighborhood tension and violence in your neighborhoods, risk factors. For sociocultural, having a bigger social network size, having more religiosity and frequency of prayer, protective, whereas more social isolation and more financial burden, risk factors. So for level 3, it's a little thick, and this is where I really, as a social psychologist, I really love spending my time here, but having depressive symptoms, neuroticism, John Henryism, so really thinking that you can do anything, you have to plow through it and just stick things out, but also perceived discrimination, all are seen as risk factors for higher levels of perceived stress, but more purpose in life, more cognitive, physical, social activity, and better sleep quality, protective. And then for biological, having vascular risk factors, actual vascular disease, and memory complaints are seen as risk factors, whereas a positive or increased global cognition is seen as protective for perceived stress. So here I did use a cohort that is exclusive to the Rush Alzheimer's Disease Center. the Minority Aging Research Study, PI, Dr. Lisa Barnes, who is here at the Rush Alzheimer's Disease Center with me, exclusively older Black adults, self-identify as non-Latino, had a non-missing score for the perceived stress measure, and no known dementia diagnosis. So overall, for this analysis, we had 722 older Black adults. Our outcome was perceived stress. We did use the 4-item measure as it was designed for brevity, especially in situations with older adults or others. It is a subjective evaluation of life as unpredictable, uncontrollable, and overloaded during the past month. It is a 5-point scale, 0 to 4, with higher scores indicating higher levels. So that's a key thing to note. As you can see, there are many different correlates. We did group them according to the NIA Health Disparities Research Framework. I won't go through all of the measurements here or the surveys, but at the bottom, you will see a website for the RADC Research Resource Sharing Hub. All of the variables, how we measure them, how frequently are found at this website. And I'm also open to talking about these measures afterward and offline. It is key to note that we did adjust for gender and age. Those are fundamental factors as dictated by the research framework. So it is important to note that we did transform the PSS total scores. As is similar with other research with older Black adults, as well as just Black adults in general, they did tend to have a skewed in lower levels PSS scores. So we did dice them into quartiles so we could understand the fullness of which antecedents are impacting for risk and protective. We then grouped the correlates into the 4 levels, and then we had separate ordinal logistic regression models for each. That means we only had a model for environmental, separate for sociocultural, separate for behavioral, and separate for biological. The reason being is we really wanted to understand what is the impact of the factors in these different levels using stepwise approach, and then confirm that to go backward to say, well, what are the true things that may be risk and protected? So here for level 1 environmental, we have 4 big factors that stood out as statistically significant. So higher income, more life space, more safety are seen as associated with lower levels of perceived stress. So that means protective. But just as we hypothesized, more tension associated with higher levels of perceived stress, so characterized as a risk factor. For level 2, sociocultural, 3 factors stood out. As hypothesized, more high financial burden, more social isolation associated with higher levels of perceived stress, so seen as a risk factor, but a bigger social network size, protective, or associated with lower levels of perceived stress. For behavioral, only 2 stood out. So this is in line with some of my previous work where depressive symptoms really align with perceived stress. And we see that in the literature where they're highly confounded. So that's something I really want to tease out in future research. This is cross-sectional, but it is to note that as we see in previous work, more depressive symptoms, more perceived stress. But this is likely a bidirectional confounded relationship. But something else that is a signal here that I find very fun and I've explored in my other work is more purpose in life. More purpose in life, lower levels of perceived stress, so a protective mechanism. And then lastly, for level 4, biological, more memory complaints, and something that we're kind of on the fence about hypothesizing, but really digging in midlife literature, higher BMI associated with higher levels of perceived stress, whereas more or better global cognition, a protective factor. So while this study adds to a small body of research that's focused on antecedents of perceived stress, but also particularly among being older Black adults, we did hypothesize that perceived stress was associated with correlates from each level. And we do have support from previous research, so social isolation, network size, these neighborhood-related factors, financial-related factors, and depressive symptoms. However, what's unique to this work is where we're signaling the importance in old age, particularly related to perceived stress, is more life space. So the more you get out of, say, your bedroom, your living room, your apartment building, into your community and beyond, the better. More purpose in life, so having a feeling of your life being dictated by a higher power, or you may just have something you need to do with your life. Global cognition, memory complaints, and BMI. suggests that these correlates are across different levels of the NIA Health Disparities Research Framework. So this multi-level analytic approach is highly important for not only understanding perceived stress, but the experiences of aging, particularly with health among older Black adults. So next steps, I would define as most correlates are potentially modifiable, as we could think of life space and other pieces. We can develop here researchers, practitioners, culturally compatible educational tools, intervention strategies, engagement, et cetera, to really figure out how to help individuals cope with higher levels or mitigate and bring down higher levels, or just not have higher levels of perceived stress in the first place. But some correlates are not modifiable, and these are primarily financial and neighborhood factors. So based on my previous research and thus that I have going on now, these non-modifiable factors may mask structural racism or other inequities, meaning that things such as housing inequities or precarity, job insecurity, pay inequities across the lifespan could really be bearing down in older age, things that we see across the life course for older Black adults, but really showing impacts for health in older age. So hence it's critical for us researchers and practitioners to really partner with policymakers to establish and implement these evidence-based structural changes. So in closing, please think of this study as an important step towards identifying, characterizing antecedents or correlates of perceived stress among older Black adults. Also, thank you for attending and listening, and I look forward to your thoughts and questions, now and later. Here's my email. You can find me on Twitter, and this is also the citation at the bottom for where all of this work comes from. And thank you.
Dr. Glover, thank you for your very enlightening presentation. And again, we welcome your questions, comments in the chat. Next, I'd like to introduce Dr. Amy Kind, who will be our final presenter.
All right. Hello, everybody. I am very grateful to Dr. the entire GSA team for arranging this opportunity to present to you today. This is a wonderful chance to talk about the opportunities to use the health disparity in the NIA in a whole host of ways. If we encounter any technical problems, I'll ask Dr. Powell. Oh, it seems like I was kicked out. Do you see me again? Yeah?
Yes.
Okay, let's try this again. Interesting. Try one more time. We had no trouble when we ran through before. All right.
Your
Yep,
sides
we're
are
good.
visible.
All right. I think Zoom was having a little bit of a hiccup. I want to thank GSA for inviting me, but also to just highlight the wonderful work that we just heard about from Dr. Bonds-Johnson and Dr. Glover. They have set the stage just absolutely beautifully for some wonderful examples and approaches for how one can use the NIA Health Disparities Framework. My job in this presentation is to link to that last box on the framework, think about those biological factors, and we're also going to talk about the framework's power in the policy space. So without further ado, we'll go ahead and get started. Just some disclosures. My funding does come from the National Institutes on Aging, National Institutes on Minority Health and Health Disparities, and the Alzheimer's Association. So we've seen this mechanistic framework a few times already. You've heard it talked about. It's very powerful. And of course, when we look at it from a very high level overview, we see that it is a multidimensional framework that covers everything from environmental to social cultural factors, all the way to individual behavioral and biological factors. But one of the interesting aspects of this framework is it's not a cross-sectional framework, it's a life course framework. So we're thinking about these exposures across the entire life course. Additionally, many of these exposures are external to the biological human. They're external to the individual, especially when we think about those environmental pieces. And so the way we think about that increasingly in this field and anchored to the NIA framework is with the construct of the exposome. So the exposome is the measure of all the exposures of an individual in a lifetime and how those exposures relate to health. Another way to think about this is, how do we link cells to communities? How do we link all of these exquisitely deep phenotyped biological samples to the social factors and social forces that surround the individuals who provided those samples? Increasingly, there's great interest in making these linkages, but just to acknowledge this, not every infrastructure is as rich and robust as the one Dr. Glover shared with us, for instance, that has all of these characterizations. So this is an area of additional research, and quite a bit more work is needed here. A way to think about this is through the construct of social biological phenotyping. So this, of course, you've heard about biological phenotyping when we think of the genetics and the omics and diving deep into a particular biology of a human. But when we think about adding those social factors, we can construct that as social biological phenotyping. It helps us facilitate this area of mechanistic health disparities research. It is embedded within the NIA Health Disparities Framework. And in the simplest way, again, it's this linkage of the community to biological processes. But it does allow us to expand and think about existing resources in new ways. The interesting thing about these exposomal metrics, these metrics external to the individual, is they also link incredibly well to policy. And let's talk about that a little bit. So they're actionable. And policy is very, very powerful. Dr. Glover talked about this at the end of her presentation, about how so many of the factors that we measure require a large group of individuals to come together, including people outside of the research space, in order to make societal change. And I think this quote from the Institute of Medicine in 2012 really hammers this home. And let me just read this to you here. Policies are fundamental, and then in their linkage to health promotion and disease prevention. They create opportunities for broad and sustainable improvements in population health. And the power of policy is exemplified by the fact that every one of the top 10 public health achievements in the last century was facilitated by some sort of policy action in order to influence practice and prioritize resources. So I bring this up because, again, many of the exposomal metrics that are used have the potential to translate to policy. And so what do these actionable metrics look like? They're often inclusive of all the targeted persons in a political unit. That is, they're generalizable. And in our research world, we would call this, of course, generalizability. But a political unit can be a city, it can be a county, it can be a state, it can be the entire United States. But ultimately, it's a structure by which decisions can be made by our leaders and resources can be allocated. These policy actionable metrics tend to be regularly updated, in that they're timely, they're available on a regular basis, they're rigorously tested, and certainly in our research world, we would call this construct of validity. They're accessible to all, they're open. If there's a policy being made about a particular metric, you want to know if that metric applies to you. So the general public should have access to these policies, these metrics, and be able to understand how they influence a single life. And then ultimately, they're constructed to meet the needs of a range of possible users. If these metrics can only be understood by individuals with advanced research training, then their chance of translating to policy is less. So metrics of neighborhood disadvantage are quite interesting, because not only do they emphasize this world of the exposome and capture some of those constructs, but they are inherently policy actionable. They tick all of the boxes that I just offered and have been used in other places of the world, in Europe by the World Health Organization, in Africa, in Mexico, in Australia. The list goes on and on for a very long time in the policy domain. But again, we can think about them as exposomal metrics. They tend to incorporate social determinants of health in a discrete population-sensitive area, which is typically around 500 to 1,500 people. And in the United States, this tends to be the metric of the census block group. We'll talk about what that looks like in a moment. They're robust in that they're harmonizable and privacy compliant. We can share them easily. They're not protected from HIPAA or other legal privacy laws. And they're actionable. They can help guide outreach and resource targeting from a policy domain. For the United States, we were interested in developing and refining one of these metrics. And almost 20 years ago now, we started work on this metric, the area deprivation, or ADI. It was originally built by the Health Resources and Services Administration in the late 80s and early 90s and needed refinement in order to bring it in alignment with these smaller geographic areas that are required to be policy actionable and exposomal actionable, and it required updates to modern data sources. Happy to talk about those at another time if it's of interest in the chat. But this is what these things look like. If you look at this slide, this map is a single county within the state of Wisconsin. This is Milwaukee County. It is one of the most challenged counties from the standpoint of social determinants of health if you use a county level measure. But at these much more discrete geographic levels, these micro targeting levels, what we see is that the area of most profound neighborhood disadvantage in Milwaukee County is clustered in inner city Milwaukee, and it's surrounded by neighborhoods that are some of the wealthiest within the state. So this really does highlight the importance of precision of measure here. And not only does this allow us to link cells to community factors in a much more precise way, it actually allows us to be more policy actionable as well. So when you think about using these types of matrices for disadvantage, whether you use the ADI or some other metric that's available in your own country or another in the United States, you want to remember some things. First of all, individual level, socioeconomics and contextual level are not the same thing. They can be quite a bit independent and are independent in their impact on health. Associations with these types of metrics tend to be very nonlinear in that individuals who are living in these most disadvantaged constructs have much tighter association with adverse health outcomes. The interpretation and application of these metrics should be informed by health disparities theory, understanding that different historical influences within any particular country are why resources are not always equally distributed. So in the United States, for instance, structural racism and the effect of redlining have strong echoes into the current measures of these ADIs. And then finally, linkage of these types of metrics to existing data relies on the availability of geographic parameters within your data. Lots of groups have used these. We give these out for free through the Neighborhood Atlas. We'll give you just some examples of how some researchers have used these metrics. So this is a presentation, a publication from Dr. Tom Gill and colleagues out of Yale, looking at not only mortality of individuals who live in these most disadvantaged neighborhoods, but also how long they lived independently. And what was found is not only do individuals who live in highly disadvantaged context have shorter lives, but the last years of their lives are more apt to be spent in nursing homes and requiring advanced care support services. In some work done with Sharon Inouye's group out of Harvard, led by Francesca Arias, who is now an assistant professor at the University of Miami in Florida, she was able to demonstrate that individuals coming in for elective surgeries, and in this case, hip replacement, had a much higher risk of developing delirium, which is, of course, a very serious complication of surgery, if they were residing in a highly disadvantaged neighborhood prior to that surgery. And of course, we know delirium is preventable. This potentially can be used then as a prospective targeting metric for programs like HELP and other delirium mitigation procedures. Linking to the brain health space a little bit more, this is some data out of our own group looking at total brain volumes and hippocampal volumes in association to where someone lives. And what was found is that, again, individuals who live in these most disadvantaged neighborhoods are showing differences in their brain structure and brain volume, part of which is being mediated by cardiovascular risk factors, obesity, diabetes, smoking, things of that nature, but some of which are not. And it's interesting in allowing us to open up some additional understanding for the influence of these environmental factors on brain health. In this same cohort, following them forward longitudinally and comparing an individual to themselves, what we found is that where someone entered the cohort and where they exited the cohort looked very different for individuals who lived in the most disadvantaged neighborhoods. So those who were living in most disadvantaged neighborhoods had faster, more rapid loss of brain volume and more rapid degeneration of their cortical structures, as well as a more rapid loss of cognitive function as compared to their counterparts within wealthier contexts. And then finally, these types of data can also be linked to tissue. Using fundamental tissue biorepositories and understanding more about where individuals lived at the time of brain donation, we can link those individuals with time concordant exposomal metrics to share that those persons who are living in these more highly disadvantaged contexts at the time of brain donation show higher burden of amyloid and tau neuropathologies. But of course, there's a lot of opportunity in this space. And this brings us back to this life course arrow that the Health Disparities Framework highlights, this idea that these types of exposures may have critical windows across the life course. What if one has exposure in childhood, but has different exposure in midlife? What about exposures in midlife? How can we interact with these factors in order to facilitate improved health for all? And so lots of opportunities exist for those of you interested in this, not only with the cross-sectional work that I just showed you, but thinking about life course assessments and also thinking about cumulative dosage and timing. So an example of this is the neighborhood study, which was recently funded just a year ago by National Institutes on Aging. This is a 22-site national consortium in which we will be using the NIA Health Disparities Framework to help us understand more about life course exposures and how they link to cognitive function change and AD-specific neuromarkers, including neuropathology over time. These are all the sites for a neighborhood study. Really, really honored to be able to work with all these groups. So these types of metrics are also available to all of you. Remember that important aspect of policy actionable metrics is that they're available to everyone. They can be accessed by everyone and hopefully understood by just about anyone. And so this construct, this idea of making research open and accessible to a wide variety of individuals within our public is called data democratization. And this is a construct that we've embraced with this tool called the Neighborhood Atlas. It was first launched with a paper in the New England Journal in 2018, and since that time has received very active traffic. We're getting about 1,000 downloads every couple of weeks. It's been brisk, but it allows for customized mapping. All of the maps I'm showing you, you can pull from the Atlas, and you can download all these data as well. There are 79 million data points, all providing ADI metrics on different vantage points for every census block group within the United States. But bringing us back to the power of policy then, part of the reason we were so interested in linking our exposomal factors to a policy-specific metric is, of course, policy is important in order to change the real world and ultimately intervene on trying to mitigate health disparities. And so excitingly enough, the ADI, this very policy metric that we're using in the brain health space, is now being used actively across a number of different policy domains. And so just to give you a few examples of this, during the COVID pandemic, there was a great need to understand how best to target resources, as well as to make difficult decisions during surge when resources were scarce. And those different ethical frameworks often used math in order to help understand how best to allocate resources. Well, those mathematical algorithms traditionally have been known to be incredibly biased against certain racial and ethnic groups, certain populations within the United States. So in order to mitigate that bias, many of these frameworks started incorporating these small level indices of disadvantage in order to give individuals who lived in these most disadvantaged contexts a better chance, a much better chance to receive the scarce resources. So an example of this in the state of Pennsylvania, one of the first states to adopt this during their 2020 surge, is that they said if you lived in one of these most disadvantaged neighborhoods within the state of Pennsylvania, as detailed by the Neighborhood Atlas, you would have a much better chance of receiving a ventilator during a surge, a better chance of receiving remdesivir during a surge, or some of the other scarce resources. In terms of thinking about where to send the nurses, where to send the outreach, where to send the vaccines early on when things were scarce, many states adopted different policies, including the state of Alaska, which adopted the ADI from the Neighborhood Atlas in order to target their resource targeting. And most recently, very excitingly, the Centers for Medicare and Medicaid Services are going to be changing the way they pay health systems using these equity-based frameworks. So there is a new model called the Accountable Care Organization ACO REACH model, Realizing Equity, Access, and Community Health. And these equity-focused payment models, here's an example here, uses the area deprivation index as provided by the Neighborhood Atlas in order to ensure that health systems who are caring for individuals who live in these most disadvantaged contexts receive additional resources to best care for those persons. Now, the way they use those resources will be tailored to an individual community or to an individual group and health system, but ultimately, the money will be there in order to think creatively, to think outside the box about addressing social determinants of health, and to think about how we can most effectively start translating all of the wonderful work that GSA members and others do in thinking about improving health for older adults and allowing those interventions to translate to the places that they're needed the most. This is incredibly exciting. It's a true dogmatic change for the United States in many, many ways. And I'd like to say that this is just the beginning. There are many other of these models in the works. They have not been formally announced yet. I'm sure CMS will be thinking about those, but we will be watching very, very closely when the first of these new initiatives formally launches in 2023. They're enrolling now. Health systems are thinking very carefully about how to align with these new ways of thinking about resource allocation. And so do stay tuned. So just to finalize then and move on to questions, some tips when I'm thinking about this area and thinking about the action that is needed. I would argue that the NIA Health Disparities Framework is a really, really wonderful tool. And it can allow you to not only think very strategically about your research programs like we heard about from Dr. Bonds-Johnson and Dr. Glover, but it can also help you think about how to translate work to action and think about the policy actionability in particular about the metrics that you choose. I would argue that many of you should consider incorporating exposomal constructs throughout your work, especially the basic scientists. If any of you are out there, this is a huge area that's open to you. You can think about health disparities from a basic science lens, much to be done in that area. And then of course, just to put a quick plug in for the Neighborhood Atlas, completely free to you, if fully NIH funded, these are data that are out there and linkable to your work. So of course, this work wouldn't be possible without a whole host of people, lots of funding, and just to acknowledge all of our sites in the neighborhood study. So thank you very much, and we'll be available for questions. Thanks.
Thank you, Dr. Kine, for that enlightening presentation. The floor is open for questions. If you will please use the chat function, and we will have these questions presented to the presenters. I would just like to say in opening that I am very impressed with all presentations, all the way from talking about stresses of aging and the social and ecological constructs, family structures related to caregiving, all the way to ways that we have to think of the environment non-modifiable, or if you will, structural factors with racism, with healthcare delivery, very powerful. And the concept of overlying geographic data on health and other data related to aging is just really revolutionary. And some of the outcomes that were presented by Dr. Kine, I think, are just so exciting. I'm just impressed that we are actually at a point where we can actually use some of these constructs to actually change healthcare, improve healthcare for individuals, and be more effective overall. And I don't see any questions yet, but I'll go ahead, and I'd like to address the first one to Dr. Glover, if I might, one that I'd like to know a little bit more about. You have a lot of data on associations with stress and many factors, particularly related to social networks, we know that the greater the social network, perhaps the more protective that is for individuals with self-reported stress. Does your data give you any idea about what models to propose? What next steps do you have in using that data? I find that very fascinating, but I don't know really how we can best promote a social network, enlarge that for individuals. Where is your research going in that area?
Yes, I agree as well. I'm very excited about that. So there are really two directions that I'm looking to go in, actively pursuing now, is not only understanding, say, cross-sectionally that social network size is important, but really thinking about the quality or what comprises that network, who's in it, how often do you see them, how are you feeling supported? Because you can have a very small or a big network size. You can see someone virtually or in person, but the quality of those connections and the nature of the relationships for those I'm interested in. But also, I'm really drilling down into what I call the 3 acts. So that's something that I've been really writing more about, as well as analyzing our data here, social, physical, and cognitive activity. So thinking through, are these different activities that you're doing in the context of your social connections? So we know that these 3 acts, either together or separately, in some way, really work together to be protective for cognitive health, as well as other health outcomes for older adults. So I'm exploring, one, what's the nature of these relationships, the quality of them, the number, but also do they foster these 3 acts to then bolster cognitive health and other health outcomes, including mitigating perceived stress or lowering higher levels of perceived stress. So that's currently where I'm taking my work, really as we speak, quite frankly. I'm excited about that.
That's very exciting. If I might address one to Dr. Bonds-Johnson as well. I'm fascinated at your interest in caregivers, and the COVID pandemic has really shown us that we are not supporting caregivers in a way that is sustainable, really. Both professional caregivers that work as nurses aides, even in home health areas, in facilities, they're leaving the workforce. We can't hire enough of them. We know that a number of nursing homes, some estimates are 10% around the country may close as a result of not being able to find individuals. We know that developing a career ladder, training, trying to have some recognition for the workforce is important. We also know that the current family members who are working as caregivers are already stressed to the max. And some states, some entities have provided direct payments to families to help mitigate some of that. And I know that these are social models, and I wondered if any of your research ideas or a background might help lead a way forward. What models are there out there? What can we do to help support caregivers and help develop the workforce from a job standpoint?
That's a huge question. Thank you. Thank you for it. You're pulling on probably two roles of my life. So I am very much research focused. And so looking at caregivers and their lived experience with caring for parents or spouses. And then I also work in the clinic. I'm a nurse practitioner at one of the only dementia-friendly primary care practice in the country. And so I see more of the workforce situation in that space, because that isn't exactly where my research is. So I guess to tackle both questions one at a time, the workforce one, I can't base this in research, but anecdotally, what I have seen is that it really does influence the culture where one works. That environment is so critical to how well the person living with dementia, the older adult, is cared for. And I feel like because policy has been lax in ensuring that these cultures are up to par, we have seen detrimental experiences for our families and the persons living with dementia. I mean, we quite often get, it feels like calls almost daily about, can we get some medicine to basically leave them drooling in the corner versus figuring out ways to be more environmentally friendly and figure out ways to support these families. But again, that's not my area of research. That is more what I see in the clinic space and what I keep telling our clinic leaders, that we need to open our own memory care units to show them what a memory care unit should look like and how it should function, and environmentally how it should run, because approach with an older adult is just so critical. How you approach them, how you engage with them is key to how their quality of life is. And then when we think about the caregivers who are caring for someone at home, you know, there has been quite a bit of work in this space, but I really just wanted to focus specifically on African-American caregivers, specifically because, you know, the research has often shown that when compared to non-Hispanic whites, African-American caregivers do better. They have less complaints. They have less burden. But then when you look at their physical outcomes, they have worse health outcomes, and they're spending more financial resources that they often don't have. And so for me, that was kind of a paradox and a tension that I just was curious about and really wanted to learn more about. And have really just been grateful for the opportunity to start this work and see what I find out. But yeah, I'm enjoying the ride.
Wonderful work that we can all learn a lot from. Dr. Kind, there is a question here that we'll address to you. Can you talk about how the Neighborhood Atlas can be used with LGBT and aging research? And this individual is interested in health screening behaviors. And one of the main challenges is finding and gathering a representative population of LGBT adults.
Yeah, I think that's a great question. And there are a number of different populations within the United States that are experience structural inequities, including racial and ethnic minorities, as well as the LGBTQ positive population. And the potential to be able to link these factors to electronic health record data, for instance, if you're looking for healthcare screening behaviors, I'm guessing that that's something that will be measured. Many times a healthcare system will have individuals' addresses within their healthcare system in order to send mailings and reminders and things of that nature. And they can link to the data sets that are on the Neighborhood Atlas. So it's a very easy linkage to perform. What that will give you are ADI metrics for the population that's being served within the healthcare system that you're interested in or working with. There are other reasons for them to do this, of course, but for the purpose of your research, then you can certainly talk to individuals, and as you screen and find individuals for your study, you can learn more about where they're living and the different types of exposures within those environments. Now, the ADI itself does not take into account individual social identity factors. It does take into account social determinants of health factors. And certainly we can feel free to contact me offline if you're interested in learning more about the mathematical builds on those. But overall, I think there is a space to include social exposomal metrics across all of these domains that we've talked about today and across all of the NIA designated health priority populations.
Thank you. That's really helpful. I actually just conducted, as part of my postdoc, a EHR part of my study, and it was really low. The LGBTQ population in the EHR is well below that 7 to 12%, and so that's why I was wondering if the Neighborhood Atlas would be helpful. But I'll definitely reach out to you. So thanks.
That sounds great. Thank you.
And Dr. Kind, just a follow-up question. What other cells to communities ideas is your group thinking about, or would you say are things that are really next hot items to address using the the area deprivation index?
So there are lots of discussions going forward at the policy space, and I'll go in that direction. Jim, I'm not sure if you want me to go in that direction, but that'll be the direction I go in. There have been a lot of interest from private insurers, and we've been talking to private insurance groups across the country right now, because so where Medicare goes, so tend to go the private insurers. So the potential here for anyone interested in health disparities research is just profoundly exciting, because if you can have ensure that the health disparities researchers, the aging researchers have voice at the table for how these resources ultimately will be used, these different resources that are coming into health systems that are being targeted in different ways, the potential to start funding things that health systems don't traditionally fund is at our doorstep. This is incredibly exciting, and hopefully can stimulate a lot more translation of what we know should be done in order to improve health and well-being. In addition, the potential to think outside of the acute care setting, I think, is upon us as well. CMS has not officially announced these things, but certainly in my discussions with them, there have been questions from groups as different as outpatient payer models, thinking about those outpatient clinics and how that type of care is incentivized, all the way through to thinking about transplant allocation algorithms. So these mathematical approaches can be very powerful. The way you designate the constructs can be powerful. And I would encourage all of you, if it makes sense, for you to think about these exposomal metrics, either the ADI or others in your research, because increasingly you may find that the payers, the individuals who are deciding where the money goes within our systems, may be interested in knowing those results. So, so yes, lots to come, lots of exciting things moving forward. And yeah, so, and if anyone on the call or elsewhere, feel free to reach out if you have further questions.
I want to thank all of our panelists and GSA for hosting this very exciting, very informative webinar. We will end the program now on time, and thank you all for participating. Have a good day.
Thank you.
Bye-bye. Thanks.